Assalamu alaikum dear doctors. In this video I am discussing about Marfan syndrome. So just introduction shortly I am telling Marfan syndrome, it is a disorder that affects the connective tissue and it is an autosomal dominant condition. So family history is present. It is due to fibrillin gene, that is fibrillin FN1 gene 15 number 15q21. Okay. Now how the signs, especially the signs, the skeletal abnormalities look. There are kyphoscoliosis, spinal deformity is present. Pectus excavatum or pigeon breast deformity. Look this, how that is present. They are normally long legs, abnormal long legs, high arched palate. And ocular changes are we find bilateral discoloration of the lens secondary to weakness of its suspensory ligament, that is ectopia lentis. So look the images, that is we find number 1 kyphoscoliosis we find, in chest we find pectus excavatum or pigeon breast deformity. They have abnormal long legs, high arched palate, and ocular changes occur, that is bilateral dislocation of the lens secondary to weakness of its suspensory ligaments, that called ectopia lentis. The image, that is also Marfan syndrome, and centrally what we find, ectopia lentis, eye changes, and foot deformity, that is pes planus. Look, pes planus. On the left side we go, in heart we find aortic root dilatations. Look, the heart, aortic root is dilatations. Pneumothorax. Marfan syndrome patient are long and thin, so spontaneous pneumothorax occur. And dural ectasia. On the right side, if we notice, we find high arc palate. Look how high arc palate is present. Then chest deformity, you also already know that pectus excavatum and pectus carinatum. And there is spinal deformity. What are that? That is scoliosis, the kyphoscoliosis. These are the present. So look this image. That is also an image of Marfan syndrome. Number A, we are finding that is long fingers that we find on hand examination, that is arachnodactyly in Marfan syndrome. Number B, that is wrist sign, positive wrist sign, that is called positive Walker sign. How they hold, and that is positive. Normal hand not that like. Number C is that Steinberg sign is positive, that is thumb sign. Look the image. Number D, we are seeing on chest we find that pectus excavatum, and we know that number E, that is we find pectus carinatum in Marfan syndrome. And on the feet, look the F number image, that is pes planus. Number G, that is arched palate. Look, that is high arched palate. And if the eye, we will find in the eye, that is dislocation of the lenses, that is upwards. And in the skin we find bruises. Look. And J number image, we are finding aortic root dilatations. J, K. L number dural ectasia we find in Marfan syndrome. Marfan syndrome patient, how generally look? They are generally tall, not obese, normal mentality and syndromic features. Puberty is normal. So they are tall and thin, not obese patient. Mentality is normal, syndromic features and puberty normal. What are the features we find in Marfan syndrome? If we check the gait and back, we know that we find 4 findings, that is pes planus, genu recurvatum, scoliosis or kyphoscoliosis, and capsulate spots. These 4 features. I am again repeating on the 4 features we find in gait and back. These are pes planus, genu recurvatum, scoliosis or kyphoscoliosis, and capsulate spots. Now if we check the head of Marfan syndrome, 4 features we find on the head. Number 1, thin long face, then high arched palate, dental abnormality, that is overcrowding, and supporting aids, that is hearing aids or glasses. I am again repeating, on the head we find 4 features in Marfan syndrome. These are thin long face, high arched palate, dental abnormality, that is overcrowding, supporting aids, hearing aids or glasses. If we check the hand of the Marfan syndrome, what we find? Arachnodactyly. We know that long fingers. Arachnodactyly, there is positive Steinberg sign, thumb sign, positive Walker sign, wrist sign, pulse abnormality, water hammer pulse, that is for hyperdynamic circulation. So in hand, what we find in Marfan syndrome? Arachnodactyly, positive Steinberg sign, thumb sign, positive Walker sign, wrist sign, pulse abnormality, that is water hammer pulse, that equal hyperdynamic circulations. If we check the chest and heart, what we find? There is murmur and scar, not only cardiac but maybe scar for tension pneumothorax. So there is scar present, not for the cardiac reasons, also tension pneumothorax. We know that they are tall and thin, so pneumothorax occur spontaneously. There is chest deformity, pectus excavatum and pectus carinatum, capillate spots or bruises. All patients with collagen disease easily bruised. So chest and heart, what we find in Marfan syndrome? Murmur and scar, not only cardiac but may be scar for tension pneumothorax. In chest deformity, we find pectus excavatum and pectus carinatum, capillate spots or bruises. All patients with collagen disease easily bruised. Then how I would like to complete my examination by formal hearing assessment, that is Bayton score for hypermobility. I would like to ask the mother about other family members with the same condition or not, because it is an autosomal dominant on fibrillin gene, chromosome number 15. I'm again repeating, in Marfan syndrome, I would like to complete my examination by formal hearing assessment, that is Bayton score for hypermobility, and I would like to ask the mother about other family member with the same condition because it is an autosomal dominant condition on fibrillin gene chromosome number 15. After the investigation we do for the Marfan syndrome, that is number 1 diagnostic, we do the genetic test, that is fibrillin gene on chromosome number 15. Number 2 lab, that is nothing lab is needed. Imaging, we do the spinal X-ray, MRI spine, we find dural ectasia. Echo, we find the aortic root dilatation or mitral regurgitations. Number 4 positive formal hair assessment, and number 5 plus slit lamp examinations for lens dislocation. We know that Marfan syndrome dislocation of lens is upward and inward. I'm again repeating that Marfan syndrome investigation, diagnostic is genetic test, fibrillin gene, chromosome number 15, lab is nothing. Number 3 imaging, we do the spinal X-ray, MRI spine, we find the dural ectasia. Echo, we find aortic root dilatation or mitral regurgitations. Number 4 positive formal hearing assessment. Number 5 positive slit lamp examination for lens dislocation, that is upward and inward. Management plan. Management plan of Marfan syndrome is multidisciplinary team I will involve, that is cardiology, ophthalmology, occupational, physiotherapy and ENT. And what advice we give in Marfan syndrome patient? We give number 1, any chest pain, ask medical advice immediately. Remember, chest pain is a red flag for Marfan syndrome. So advice I am telling, number 1, any chest pain, ask medical advice immediately. Number 2, follow up with the cardiac doctor to measure the aortic dimensions and plot in specific center. Number 3, advice for hypermobility. These are strengthening muscles around joints. Swimming is good and avoids exercise that cause additional stretch on joints ligaments. Attention should be paid to appropriate footwear and awareness of posture to prevent the development of chronic pain. And use the wider pencils as easier to grip as they have difficulty grasping pens or pencils. So I am again repeating the advice. What advice we give in Marfan syndrome? Number 1, any chest pain, that is a red flag, ask medical advice immediately. Number 2, follow up with the cardiac doctor to measure the aortic dimension and plot in specific center. Advice for the hypermobility. Number 3, these are strengthening the muscles around the joint. Swimming is good and avoid the exercise. This cause additional stretch on joint ligaments. Then attention should be paid to appropriate footwear and awareness of posture to prevent the development of the chronic pain. Use wider pencils as easier to grip as they have difficulty in grasping pens and pencils. Note, important positive sign we find in Marfan syndrome I already discussed. These are thumb sign, positive Steinberg sign, that is. Wrist sign, it is another name is Walker sign, and chromosome number 15 also we find in Prader-Willi syndrome and Angelman syndrome. So what is the causes of chest pain in Marfan syndrome? We already know, that is spontaneous pneumothorax and dissection of the aorta. So the chest pain cause of Marfan syndrome is spontaneous pneumothorax and dissection of aorta. The disease is homocystinuria. We know that homocystinuria and Marfan syndrome similar presentation, but that is a different. So homocystinuria is a cousin of Marfan syndrome. What are the symptoms and signs we find in homocystinuria? These are dislocation of the lens, there is nearsightedness, glaucoma and osteoporosis. Now I am telling the trait of Marfan and homocystinuria. So Marfan syndrome is an autosomal dominant condition. Chromosome 15 is involved, where homocystinuria is an autosomal recessive conditions and chromosome number 21. Number 2, Marfan lens is upward and inward and homocystinuria is downward and outward. Mentality is Marfan syndrome is normal, where homocystinuria is submental. Marfan syndrome faces is thin, long face, where homocystinuria is non-specific. Joint of Marfan syndrome is hypermobility, and homocystinuria there is multiple contracture. In cardiac Marfan syndrome we find it is aortic root dilatation and mitral regurgitation, where homocystinuria cardiac features is normal. Bone Marfan syndrome is normal. In homocystinuria that is osteoporosis. Urine is normal in Marfan syndrome, but homocystinuria we find in 24-hour increased homocysteine in urine. And lower limb we find Marfan syndrome pes planus, where homocystinuria we find pes cavus. Blood in Marfan syndrome we find platelet dysfunctions. In homocystinuria we find thromboembolic complications. Now what are the investigation we do for homocystinuria? These are diagnostic or genetic and increase the homocysteine level in urine, that is cystathione beta synthetase deficiency. Lab we find coagulation profile, there is increased tendency of thrombosis. Multiple thrombosis may affect the kidney. We do the renal function test. Imaging we do ultrasound of the abdomen, MRI brain if needed. We find hemiplegia, DEXA scan for osteoporosis, and plus slit lamp or X fundus optic atrophy. Can I end the examination in homocystinuria? I would like to complete my examination by developmental assessment. I'd like to ask the mother about if he goes to school or not, type of school, history of seizure and behavioral abnormality. We know that Marfan syndrome is normal, where homocystinuria is mental abnormality presence. Management is that how dose of vitamin B6 if seizures and EEG. Number 1, if responding, folic acid, vitamin B6 and vitamin B12. Number 2, if not responding, we give the biotin and diet low in methionine improve the lens dislocation, seizures and learning problems, aspirin and statin. Follow-up of homocystinuria patient is that check the homocysteine level in fibroblast, ophthalmology and DEXA scan. So this is all about Marfan syndrome and homocystinuria. Please do subscribe and share MRCPCH with Dr. Emma Choudhury. Thank you.